Hi, and welcome back. My name is Maureen Oscadal, and I'm a registered nurse in Seattle, Washington. And I'm here with the University of Washington's Addictions, Drug, and Alcohol Institute, and this is the Foundational Nurse Care Manager series. In this next video, we will review medications for opioid use disorder, and we're going to get started now. So to set the stage, first and foremost, it's important to note that medications for opioid use disorder, like buprenorphine and methadone, are life-saving. We see evidence for this in this graph here, which compares death rates between the general population to people living with opioid use disorder, or OUD. The green bar at the top represents the death rate for the general population. The red bar in the middle represents the death rate for people with OUD who did not take medication for opioid use disorder. And the blue bar at the bottom represents the death rate for people living with OUD who did take medication for opioid use disorder. And what we see is that the death rate for people living with opioid use disorder who did not take medication for opioid use disorder was significantly worse than both for the general population and for the population of people who had opioid use disorder and took medications for opioid use disorder. As a side note, you'll notice that on this slide, they're referring to medication-assisted treatment, which is an older term. As of right now, in 2024, the preferred language in healthcare settings is medications for opioid use disorder, or MOUD, and sometimes referred to as MOUD. So a main takeaway here is that medications for opioid use disorder, or MOUD, are the standard of care for opioid use disorder treatment, and in this session we will review which medication options are available. As this graph indicates, one of the goals of MOUD is to prevent symptoms of withdrawal and cravings for opioids that can occur in opioid use disorder. Another major goal that we reviewed on the previous slide is that MOUD can save people's lives, both by preventing overdoses as well as preventing health risks associated with ongoing opioid use. There are 3 medications approved by the FDA for the treatment of opioid use disorder. They are methadone, buprenorphine, and naltrexone. This graphical depiction shows each of the 3 medications along with their opioid effect as the dose increases. And as you can see, each one is different in this regard. Methadone at the top exerts full opioid effect, which makes sense because it's a full agonist opioid. Buprenorphine exerts a partial opioid effect, which aligns with it being a partial opioid agonist. And naltrexone at the bottom exerts no opioid effect. It actually antagonizes or blocks the opioid receptors. So next we'll review the 3 medications in a little bit more detail, starting with methadone. So as you can see here, methadone is a full opioid agonist. It's a synthetic opioid and it is a long-acting opioid. As an opioid, it has no ceiling effect, which means that with each dose increase, you expect to see more and more of an opioid effect. For opioid use disorder, dosing of methadone typically starts around 30 milligrams a day and titrates up. Methadone is a longer-acting opioid, and as such, oftentimes people only need to take 1 dose a day. And in the United States, methadone is restricted. It can only be available for opioid use disorder treatment in federally licensed sites called opioid treatment programs, or OTPs. And patients typically have to start out by taking their doses under observation daily, and may eventually be granted the ability to take short durations of doses home with them. But in the United States, methadone is not available for prescription for patients with opioid use disorder. Again, they can only get methadone dispensed to them by OTPs. The next medication we'll talk about is naltrexone. And naltrexone is a full opioid antagonist, meaning that it blocks the mu opioid receptor, thereby blocking any effect of any opioids that may be taken. The formulation of naltrexone that's approved for opioid use disorder treatment is Vivitrol, which is a long-acting intramuscular injection that's given monthly. It's worth noting that naltrexone is also approved for the treatment of alcohol use disorder. Because naltrexone blocks the effects of opioids, a person does need to be opioid-free prior to getting the first dose. Otherwise, the dose of the naltrexone will precipitate withdrawal. And precipitated withdrawal refers to opioid withdrawal that is precipitated by the initiation of a medication like naltrexone, which outcompetes for the opioid receptors, resulting in opioid withdrawal symptoms. The third and final medication that we'll cover is buprenorphine, which is sometimes referred to as bup. Buprenorphine is a partial opioid agonist, meaning it partially activates the opioid receptors. It has a strong affinity for the mu opioid receptor, which means that once someone is stable on a dose of buprenorphine, if they take another full agonist opioid, the buprenorphine outcompetes for the mu opioid receptor and can blunt or block the effects of the opioid. Unlike methadone, buprenorphine does have a ceiling effect. Buprenorphine is available in two forms. It is available as a sublingual tablet or film and as an injectable. The sublingual tablets and films are available by prescription, which means that patients can pick those medicines up at a pharmacy. The injectable versions are only available to be administered by healthcare workers. In the next session, we'll review buprenorphine in a lot more detail, including the different formulations and important considerations when starting the medication. As we've already mentioned, MOUD is the standard of care for opioid use disorder treatment, which means there is strong evidence for its use in treatment. In the next few slides, we'll review just one study highlighting this evidence. So this is a retrospective study looking at the effects of medications for opioid use disorder in a cohort of adults without cancer in Massachusetts who survived an opioid overdose between 2012 and 2014. And 12 months after the non-fatal overdose, the researchers found that 2,040 of the people, or 11%, had enrolled in methadone for a median of 5 months. 3,022 of the people, or 17%, had taken buprenorphine for a median of 4 months. And 1,099 people, or 6%, received naltrexone, which was Vivitrol, the injection, for a median of 1 month. So moving on, at the study's conclusion, when compared to no medications for opioid use disorder, methadone and buprenorphine were associated with reductions in both all-cause mortality and opioid-related mortality. And here we see the breakdown. There was a 53% reduction in all-cause mortality and a 59% reduction in opioid-related mortality amongst those who enrolled in methadone compared to no medications for opioid use disorder. There was a 37% reduction in all-cause mortality and a 38% reduction in opioid-related mortality amongst those who received buprenorphine compared to those who took no medications for opioid use disorder. And Vivitrol, on the other hand, was not associated with reductions in either all-cause mortality or opioid-related mortality compared to no medication for opioid use disorder. And these findings are consistent with other studies, which have shown that medications for opioid use disorder, particularly buprenorphine and methadone, are effective treatments that are associated with improved health outcomes and reduced risk of death. So when we talk to patients about medications for opioid use disorder, it's best practice to provide information and education about all three treatment options. And shared decision-making is the practice of including patient preferences, goals, and needs when determining whether to start treatment and which treatment is chosen. And this practice gives patients a say in their own treatment, it recognizes that they are the experts in their own lives, and it improves engagement and adherence to care. A guide to medication for opioid use disorder shared decision-making is available at the website learnabouttreatment.org. And with each of these medications, it's important to not only consider the pharmacology, but also the context in which the medication is offered. So when we review these aspects with the patient, this can actually help the patient decide what's going to be best for them, which really sets the stage for success. And you see here on this slide the three medications available, methadone, buprenorphine, and naltrexone, organized by the form of medication, the setting in which it's offered, the potential visit frequency, and whether counseling is required. And as you can see here, things can vary, and they can vary by program. So as a nurse care manager, it's particularly helpful to know what services are available out there, what the programmatic requirements are for, say, the methadone treatment at your local OTP, so that you can talk to patients about their options and they can know what to expect. And before we wrap up, it's important to talk through a couple of common patient concerns that come up when we're talking about medicines for opioid use disorder. The first one is this: I don't want to trade one drug for another. This is a common concern, and it may be influenced by patients' previous treatment experience, sentiment within their social support system, or messages from others in their lives. Regardless of the source, the concern is valid and it's really worth exploring with the patient. So here are some possible responses. It can be really helpful to just ask more questions. For example, what does recovery mean to the person? It can also be helpful to explore how medications for opioid use disorder might allow the person to engage in other areas of their life that they haven't been able to do so recently. If they've taken medication for opioid use disorder before, which one was it? What did they notice? How did it go? And how is life different when they were taking the medication than when they're not taking the medication? It can also be helpful to talk to patients about the difference between opioid dependence and opioid use disorder. This is by no means an exhaustive list. Consider what else you might offer when you hear somebody propose that they don't want to trade one drug for another. Another common concern that comes up is, I don't want to take this medication forever. And this is totally understandable. Very few people like taking medication daily, especially long-term, and it is helpful to understand reasons behind this sentiment. Again, in this case, asking questions can really help the patient and provider come to an understanding. So for example, what do they want to get from treatment? What are their hopes? What are their goals? What do they think will help them get to a place where they feel satisfied with treatment? Again, what does recovery look like to the patient? Some of the more important things to consider and to talk about are, what do they like about the medication and what don't they like about the medication? And consider things like logistics, such as the pill burden and side effects of the medication. Again, this isn't an exhaustive list. What else could you possibly say in response to the concern, I don't want to be on a medication forever? So before we wrap up, there is one more medication that we need to cover, and that's naloxone. Naloxone is an opioid overdose reversal agent, and it's available as an intramuscular injection or an intranasal spray. There's no prescription needed. It's available over the counter, although without a prescription, the cost can be prohibitive for some people. It is available for free in Washington. It's available for free through syringe service programs, emergency departments, behavioral health programs, and in other settings. More information about how to respond to an overdose and where to get naloxone is available at stopoverdose.org. And this concludes the second video in the series. In the next video, we will review buprenorphine and buprenorphine naloxone in more detail. Thank you for joining me.